Everybody, while we eat, I think everybody might prefer if we got started, so we didn't wait till after you ate and then we waited and got a late start, etc. I want to thank you for coming. My name is Matt Ethington. I am the founder and CEO of a company called ChronicCareIQ that's based out of Atlanta. We had looked for a long time to find a partner to work with in Texas, and we selected digital telehealth solutions out of San Antonio because they were already performing remote patient monitoring for Medicaid patients. If you got the handout on your way in, it's incredibly lucrative. I couldn't believe it. I feel a little short after seeing that. And what we do is we do Medicare remote patient monitoring, chronic care management, and transitional care management. And all of those bundled, we refer to that as remote patient management. It happens to tie nicely into all the changes that the government is forcing you into with value-based care. So the goal of my presentation today was to bring clarity so you could leave here and just have a little bit of clarity with what's going on at the government level, at the transition level, because it's been so noisy for so long. Especially if you're clinical, you've probably checked out. So I'll bring everybody up to speed on what's going on and what's important right now. And then have a good understanding of what the timing is and what's important and what's not important and what actions should be taken, what actions can be taken, and then understanding how to win with value-based care because it's completely possible. I had just mentioned that I felt a little small, I guess, compared to the state Medicaid reimbursements, but the fact that you can do Medicaid and Medicare on our platform, I wanted to project something really quick. I just ran, after I saw that number, this is a 2-doctor practice. They were our 5th customer. They're only 3 miles from our office. They're 2 internal medicine doctors. They are concierge physicians. They see about 400 patients each in their panel. It is very difficult for them to expand their revenue. You can't just go out and find an additional patient that's willing to pay $2,000 a month to be your patient. They selected ChronicCareIQ to help them remotely manage patients because they do have a panel of fragile patients that do require a lot of work. They became our 5th patient. What I wanted to show you was in 2017, the beginning of 2019, Medicare introduced a reimbursement that pays $54 per patient per month when you can show that your staff has spent 20 minutes or more of interactive time communicating with a patient. So they were already set up doing chronic care management. We'll get into that a little more. But right here, this was December of 2018, and you look at where their revenue's gone. In addition to their chronic care management, they're now earning remote patient monitoring reimbursements. This green line represents their revenue. The blue line represents how many patients they've enrolled, and the orange line represents how many patients that were billable that month. So what you'll see here is, and this isn't a canned show that this is actually the reports that they get on a weekly basis. This isn't a canned Excel spreadsheet that I made for you to see something. This is what they get. Essentially, without adding staff, without adding third parties, they have added $15,000 in monthly recurring revenue, and you can see what the trend is. So how do you do that in value-based care? This happens to be something that they're just going to max out value-based care. So I'll go back to the other presentation, but what I wanted to show you is especially if you have a high volume of Medicare patients, if you have fragile patients, labile patients, brittle patients, what they're called, there's a great platform to reduce the amount of attention that those patients require, to kind of ease the clinical burden of those patients, and certainly reduce the administrative burden, reduce inbound phone calls so nurses have time to be proactive outbound instead of constantly reacting internally. I'm going to get into my next presentation, just a high-level overview of what value-based care means. This is a scatter sheet on a physician community. And over here in the lower left quartile, it shows patients that are high cost with poor outcomes, or doctors whose patients have high cost and poor outcomes. Over here in this scatter page is high quality and low cost. Medicare's initiative behind all of this is to move doctors from this quartile to this quartile. Do they know how to do it? The answer is no, they do not. They don't know how to do it. What they have done is decided, going back quite some time ago, to introduce carrots and sticks. And it goes back a long ways. It goes back before 2006, but these are just some milestones. I won't read all of them. But this was the first one. This was when they invented something called PQR. It wasn't PQRIS, it was called PQRI. And they paid doctors a 1.5% bonus if they would report on 4 quality measures in their practice. It's the first time they ever introduced something like that. Happened in 2006. I happen to be very familiar with EHR and meaningful use. We're not going to talk about it because I don't want any of you to start throwing things at me. But that really started kicking this off as to where it was going. 2010, they changed just bonuses to also including penalties. So that's when now the sticks came out on reporting. You had to report on, we wanted you to report on this many activities, we're going to punish you if you don't report on these activities. That model, carrot and stick, is what's being followed in value-based care as that transition occurs. Lest you think it's not happening, 2019 year became your baseline measurement year for what Medicare is measuring your practice on. They don't have to ask you for it. They already know how much your practice is costing Medicare, and that's a big component of what we're going to talk about. It's a big component of MACRA. MACRA was introduced late 2014 is when they ended how doctors used to be paid with the sustainable growth rate, I think is what it was called. It was one of the only acts in that administration that had both sides of the House and both sides of the Senate were able to compromise and vote on. But MACRA, 2015 was a huge year for noise, right? MACRA introduced, well, you can only get paid in one of 2 ways. From the sustainable growth rate and your fee schedule, you can now be paid in one of 2 ways. You can participate in an alternative payment model, which is kind of like a capitated prepaid model for some of your patients. Do any of you have CPC Plus patients? Okay, good, I get to stay out of that. That's called an alternative payment model. Back then in 2015, if you had $30,000 in reimbursement on Medicare patients, you were automatically enrolled in MIPS, whether you liked it or not. You could not sit on the sideline. Now that's $90,000. So the stakes are a lot larger, the penalties are a lot bigger. So you're able to sidestep this if you don't bill more than $90,000 annually to Medicare. But if you do, you're in whether you like it or not. And if you don't follow what's happening, you're going to get penalized. And if you do get penalized, you are paying for the bonuses of the doctors down the street, because the penalties that are going to happen around value-based care is a zero-sum game. You will be a winner or you will be a loser. And if you are a loser, you're paying the winners. So that makes it a little bit different, makes a little higher sense of urgency. They introduced, 2015 was also the first year that they reliably started paying doctors to perform services for patients when they're outside the office. Prior to that, it was all bundled into office visits, right? The patient came and saw you, you needed to check on them a couple times a week. Well, you're supposed to do that anyway, so it was just included in your E&M visit. In 2015, they introduced a reimbursement called Chronic Care Management. If you had 20 minutes of non-face-to-face activity that you could document your staff performed, you could bill for $42 was the average for that patient in that calendar month. It didn't do very well in the market because they said you had to document that 20 minutes. So that meant everybody had to get out a spreadsheet. I had a 3-minute conversation. I do 2 medication refills. I was on hold with the pharmacist for 11 minutes, and then I talked to him for 3 minutes, and then we did a pre-cert, and it was death by 1,000 cuts. Right? You can't even pay a staff member to record that information for $42. So what happened was a bunch of third-party call centers came in and said, you know what? We'll call your patient. We'll talk to him for 20 minutes. We'll give you a note, and then we'll take half of your reimbursement. That hasn't worked out for very many people either, because half of your reimbursement is $21. It's difficult to get the copay, which is $8, so you're holding the basket for $13 in reimbursement, and you have to write them a check, and it's like, ooh. So it just wasn't worth it. But it got the tables turned. It got people moving in that direction. In 2017, they said, look, this is a big part of what we're doing. We're not getting the uptake. They added 2 more reimbursements. Said for signing the patient up, you get $64. If you can establish 20 minutes, you get $42. If you can establish 60 minutes, you can get $100. And if for every 30-minute increment thereafter, you get another $50. So all of a sudden, things turned a little bit. But patients still had to have 2 or more chronic diseases. They still have to consent, and only 1 doctor could do it. So if the cardiologist was already doing it, or the pulmonologist was already doing it, or the internist was already doing it, and you did all that work to submit a bill only to find out that they're not going to pay us, right? That's not reliable. So in January of 2019, Medicare said, hey, we're going to go ahead and add remote patient monitoring to this list. If you can show that your doctors or your staff have exhibited 20 minutes or had 20 minutes of interactive communication with a patient, then we'll bill you we'll pay you $54. So that's a lot easier to govern. You don't have to do a care plan. More than 1 doctor can bill, and you just have to show us that somebody's had interactive communication with the patient. So now, if you're actively monitoring patients outside the office, you have a way to bill for your phone calls, your phone time. You have a way to bill for those activities if you have something that can bring it all together and track it for you. And that's what ChronicCareIQ does. So, and I'm going to dive into that. I'll show you that. But I wanted to show you the transition to value is taking place. The bonuses started out around 4%. Let me go to that slide. You know what, real quick, here's where it's going. Here's where it is right now. So there are 7 codes that pay up to $264 per patient per month. They exist. We've got EOBs on them from around the country. We do this for doctors and patients from Hawaii to Maine, from organizations as small as solo primary care providers, as large as HCA. The goal of Medicare also announced this year is we want to move everybody away from fee-for-service. That's frightening. But that's what they said their goal is. They stated that. Alex Azar, is that his name? Said that in one of the speeches when they announced patients over paperwork. So 2020, there are going to be more of these reimbursements. They've already added to CCM reimbursements. If you're familiar with TCM, which is Transitional Care Management, it is, for all practical purposes, an office visit after the patient is discharged. If you can show that you contacted that patient within 48 hours or 2 business days of their discharge, and that you had seen them within 7 days for a complex patient and 14 days for a moderately complex patient, you can bill TCM instead of the regular E&M visit, and it's basically twice as much. The reason for that is 1 out of 5 Medicare patients is readmitted within 30 days. And they want to cut that down. That's a $17 billion savings. But there's not been a big uptake on TCM. So they're trying to increase the money. So when I said Medicare does not know how, they just keep throwing money out there, throwing more and more carrots out there so that you'll figure out how. I happen to be a chronic patient. I'm also a technology developer that's been in healthcare for 20 years. I'm the founder of this company. I know how. I'm going to show you how. And like I said, we've had success. I showed you just one company's success earlier. But the sticks are now coming out because you are being measured. I'll go to that on another slide. You are being measured. And if you perform poorly on those measurements, then you will be penalized. And your penalties will go to pay the doctors that are ahead of the curve. So that's irritating. 2021, they introduced fixed office visits. So beginning in 2021, all your office visits will be flat rated, whether it's a level 4 or a level 1 or a level 2 or a level 3. So that's a little bit more of that push to value. But the words, what they say, they've said so much, right? You've heard of PQRS, you've heard of MIPS, you've heard of MACRA, you've heard of VBM, you've heard all, it's like, you finally are just like, look, let me see patients. You're killing me with this BS, meaningful use, EMR stuff. Just everybody be quiet for a while, right? We're hung over from that. But they haven't stopped moving. And it's starting to become important. This is indirect revenue that you can make or pay. This is essentially what MIPS is. MIPS says, so you started getting measured here. If you didn't submit or you didn't have enough revenue, Medicare revenue to be eligible, we'll do another presentation, a CME certified presentation, into much more detail on MIPS. But it says you are going to get, MIPS is essentially you as a provider or your provider will get a composite score. In 2017, it was heavily weighted on quality, 0 on cost. Improvement activities are things that you're doing that are innovative in your practice. You can have 2 heavily weighted activities or 4 regularly weighted activities or 8 lightly weighted activities to max out that category. Promoting interoperability is how you're technically working with your patients or working with other providers in your community to stay connected. So it's connected cares is kind of what they call it. And it's 25% of your score. Here again, you can perform 2 heavily weighted activities, 4 moderately weighted, or 8 lightly weighted activities to max out that score. This is 2019 where we're at today. Quality, which is how you perform on what you've reported. So quality is how many of your hypertensive patients have their blood pressure in the ideal range. How many of your diabetics have an A1C below 9? How many of your patients that have had a heart attack are on aspirin therapy? How many and your EMRs are supposed to help you report all of that stuff. Cost, essentially, Medicare would a lot rather pay for your office visit than a hospitalization. So they already have that information. And then important improvement activities, and so you can see that these two are the same, that they brought down the influence on what you have to report. Here's what I want to tell you about what we do, and then I'm going to show you how we do it. We greatly improve quality because I can tell you as a diabetic, a type 1 diabetic that's a little bit different, everybody leaves their doctor motivated. Right? They wouldn't go to the doctor if they were unmotivated. I'm going to get home, and they said I need to get in shape. So I'm going to have a big salad, I'm going to stay away from the ribeye, and I'm going to talk my wife into taking a walk with me, and I'm going to get up early and do sit-ups. And then you get home and the real world, crashes in. The dishwasher's broken. Your son got an F on his math test. Your wife is angry as all get out because you promised you were going to do X, Y, and Z, and there's no salad in the refrigerator. You're like, tomorrow's my day. I'm going to swing by the grocery store. And then real life gets in tomorrow, right? And then four days from now, I'm already fully back into my life. So one of the special things about our platform, and it's something that the office doesn't have to do, is it remotely engages patients. And by that I mean it pings patients and it gathers updates and it talks to your patients. It enables your EHR to talk to your patients and ask them questions. Did you exercise? What was your blood sugar when you woke up this morning? The questions that are asked match the profile of the patient in your EHR, match their problem list. So if it's a heart failure patient, we're going to ask, what did you weigh this morning? Have you noticed any new swelling? How many pillows did you sleep with last night? If they have comorbidities of depression and rheumatoid arthritis, maybe they're secondary, maybe they're tertiary diagnosis, but once in a while I'm going to throw in there, have you had more good days or bad days this week? And I forgot the other comorbidity that I mentioned, but they're related, they're patient specific, they're dynamic, and they're related. And then those patients are scored on the backside on a color-coded dashboard when the patients have exceeded a threshold, if they're trending in the wrong direction for too quickly or too long, and if they just stopped answering. So if they stopped answering, we hit their caregiver or their patient advocate, and we say, hey, your mom has not answered the questions that we normally ask her. In my family, no one's afraid of me. Everyone's afraid of my sister, who teaches special needs children in Denton, Texas. So she calls my dad in Atlanta, Georgia. She's like, Dad, I know. And then he gets back. If I call my dad, he's like, leave me alone. So we're able to introduce that social reinforcement. But here's the amazing thing. We get 85 to 93% patient utilization on any given week. And we get that for a lot of reasons. But if patients won't use it, it doesn't matter. If your staff won't use it, it doesn't matter. If it makes you have to document extra stuff at the end of every given week, it doesn't matter. If you don't have good reporting on what you've done, because sooner or later Medicare audits everyone, it doesn't matter. You have to have a strategy. If you're going to participate in value-based care, you need a strategy, you need actionable things that can take place, you must have patient engagement, and you better sure as heck have good documentation. So but what's in it, right? I started with indirect revenue first. I'm going to show you how it pays for itself. When you do this, it introduces a new golden age of medicine. But what happens, whether you like it or not, is this. And you will get a plus 4% or a minus 4% return on your MIPS score. You're either going to be getting 4% more for all of your Medicare reimbursements or 4% less. It goes to 7% in 2021. So what you're doing this year, you'll be reimbursed for in 2021. So depending upon how you perform this year, this is where you will be. So if you think, I'm not going to submit those measurements at the end of the year, remember, in 2021 that'll come to haunt you. And in 2022 it'll be 90%. Now this year, the reimbursements weren't that bad because they said you only had to send in, I think it was 3, maybe 4 measures that you performed on. So a lot of people submitted. Everybody performed on smoking cessation because it's easy, and it didn't generate a lot of penalties. It was really easy. This year, it's not so easy. And next year, it's going to be even harder. So you'll want to have those things in mind. We hit quality because we engaged the patients. Not like we're holding them accountable to themselves, but it's just nice to know. Like you can watch some of the videos on our website where patients talk about, it helps me remember. It helps me remember to do this, to take my medication. And a lot of them say, like, some days as you get older, one of my favorite patients said, some days as you get older, you forget, did I do this or not? So now my phone buzzes and I look at it and I think, oh yeah, I have to do that. And I was like, God, if that starts happening when you get older, it happens to me now. So I'm going to be in terrible shape then. Cost is fantastic. We did a 2-year retrospective study at an Ascension hospital in Birmingham, Alabama, with a cardiology group. And it was retrospective, it was real data, and it showed that the patients on our platform had a 29.3% reduction in hospitalizations and had a 29.8% reduction in 30-day rehospitalizations. The magic there isn't us. The magic there was our doctors were able to identify which patients were getting into trouble prior to the point that they decompensated, that they had to go to the ED. And as you all know, if you're over 65 and you show up in the emergency room, they're not letting you go home. You could be perfectly healthy, but you're not going home because they don't want to get sued because they sent you home and then you have a heart attack for an entirely different reason. Right? So we're going to admit you for observation. So that's the point. The costs don't happen in your office. Medicare doesn't care about a $120 office visit. They care about the $12,000, $15,000, and $20,000 hospitalization. The only way to stop the hospitalization is before it starts on the way to the emergency room, at least for those chronic patients. So it has a big impact on cost. It is a heavily weighted improvement activity. So you don't have to do 16 or 8. It is a heavily weighted promoting interoperability activity. And that's a nice thing to check that box. So if you're planning, if you are going to be engaged with MIPS, and every consultant on the planet highly recommends it, because if you're not, you're planning on giving up 9%. This centralizes those activities. Here's the direct revenue. Before I go into the direct revenue, what I want to show you again is this. This blue number, this group only has maybe 600 patients in their panel. This blue number represents how many patients they have enrolled. The orange bar represents how many patients were billable that month. So you can see this is a very high performing service. It's not a service that we enable you to give a service, but it's a very high performing activity. If you've got this many enrolled and you're able to bill on this many, well, now all of a sudden that's a little more palatable than, yeah, you can do this, this, and this. Oh, and here's my favorite one, because I've been in medical sales for a long time. If you buy this device, you'll be able to bill $986 for your patients. And you call Medicare and they're like, denied. Right? There's no devices to buy here. This is technology that proactively engages your patients. But this is the percentage of patients that were billable, and that's the revenue. And I'm just going to slide down a little bit to show you again. I can blow it up a little too here. And you will get these reports. So if you're an administrator at the office, I manage by the numbers. I built all of my businesses by the numbers. You have gut feelings, but my business partner is an engineer, and he doesn't believe in gut feelings. And I don't always do well with them either. They have 206 patients enrolled. They billed 195 of them. That represents 94% of their patients they were able to bill on. And their total billables were $15,148. Where did those billables come from? Again, it's the numbers that matter. They don't do TCM because hospitalists see their patients at the hospital. And they discharge to the hospitalist. 173 of those patients could be billed for CCM. 111 patients could be billed for RPM. So that's 284. I want to see if that number's higher or lower. That's 284, but wait a minute, I thought you said they only have 206 patients. RPM, 20 minutes of interactive communication with the patient, and CCM are simultaneously billable. The total reimbursement in this year can be up to $264. It would have to be a train wreck of a patient to get that high. But even at the lowest levels, there are $69 of, if you get clinical data from a patient, if you get vitals on 16 days, that's a $69 reimbursement. When you have $20 of interactive communication, and your nurses are on the phone all day long, right? We plug into your phone system and we gather that time for you. Your nurses don't have to record anything. There's not even any double documentation with the platform. So they're simultaneously billable. And chronic patients, think about it, you don't pay a doctor $2,000 a year to see them if you're stable. And think about all of your high maintenance patients on 11 medications. They tell you that they're white coat hypertension. I can tell you that white coat hypertension is really only hypertension, at least in our patient panel. And we do this for tens of thousands of patients. We push 650,000 data points a month. White coat hypertension almost doesn't exist in our panel, right? It certainly does. I'm not a doctor, but I know. But the numbers show me that patients say, "Oh, it's only high when I'm at the doctor's office." Well, that's what you thought, because when you go home and you started reporting it, like, "Oh, well, we better bring that down." I don't know. You're smiling so big. I think I forgot what I was going to say next. All right, I'll move back to the app. I'm sorry, but they're simultaneously billable, and here there are. And we're going to give you our contact information. Again, we have CME accredited MIPS presentations that you can attend over lunch online. You can watch those. this is just a review of what I was talking about MIPS. I don't think people think that it's important enough, right? Because we're so overwhelmed with non-clinical activities that must be performed and just nonsense. Every other day somebody's got something new to say about this or about that. It's impossible clinically just to keep up with clinical advancements, let alone all the changes that they've made. It's like billing now. It's like a puppy that somebody's played with too much and it's like crawled under the bed and it's not coming out, right? But CCM, here are the three biggest reimbursements. TCM. TCM is going up. They announced that this week. It's already paid. What do you get for a 99494? Like $120, $110? All right. So somebody say 700? Oh, so I'm moving to Texas. So 99495 is $106, it's a $65 increase. It's the same visit. But if you have a place where that says, hey, these patients were discharged, we plug into the hospitals for you, and you have on account downtimer, you have 18 hours and 46 minutes left to call this patient, and that goes directly to your schedule or to your front desk, they don't have an excuse for not doing it. Information's right there, it's actionable. Again, that was one of my keywords, it has to be actionable. So then you can bill that because it's the same office visit. And that's a complex visit. So if it's a higher level visit, then it's $234. $65 means something. But these are the good, because this is monthly recurring revenue for your practice. Right here. These are going up again in 2020. And they're adding, so people that have tried chronic care management, there were two things, especially for specialists, that struck them sideways. Is they think, oh, that's only for primary care doctors. In value-based care, the primary doctor is measured quantitatively, not qualitatively. If you're the cardiologist or you're the pulmonologist or you're the hepatologist treating a fragile chronic patient, you are the primary because the patient is spending more money and more office visits with you than they are at the family practice. So just remember that. But RPM, which pays 30% more than chronic care management, more than one doctor can bill. Don't have to do a care plan, don't have to do anything. 99453, if patients there and say, hey, would you be, chronic diseases are responsible for 7 out of 10 deaths. It's the largest cause of lack of independence for seniors. It's the largest cause of financial bankruptcy. It's the largest cause of, not lack of independence, amputations, like that declining quality of life. It's not because we don't have treatments. And it's certainly not because we, your healthcare team, don't know what to do. It's because we don't know when. So if you'll answer a few questions when we send them to your daughter, or we send them to you if you're using a smartphone, or we send them to your email, even if we call you and have somebody ask you them, if you're willing to participate in that, our doctors are willing to monitor you. Because 7 out of 10 deaths and 68% of all Medicare beneficiaries have 2 or more chronic diseases. And it's the number one cause of death, 7 out of 10, the most deaths. For non-lethal chronic diseases, they say yes. We have the Texas Liver Institute. Does anybody, we're not in San Antonio, sorry. But there's a worldwide premier hepatologist. And we asked him, how many of your patients say no? He said, none of them. It's like a prescription to them. And when they understand that an $8 copay is a lot better than an $8,000 ED visit, and they're going to get that high level of attention, they get involved. And you saw the red and blue graph. But when we get serious and you talk to Rosa, references are certainly available. I would never buy anything, especially not from a technology guy without a reference. The only difference between a technology salesman and a used car salesman is the used car salesman knows when he's lying. I have EMR, right? It's going to increase your productivity. Raise your hand if you heard that. So here's the thing. This is what Medicare's trying to solve. I just mentioned it. Readmissions, the high cost of chronic disease. This number, 99% of Medicare's payments, is actually from CMS. We have it documented. We can show you the link where you can go to get 99% of their payments are made on behalf of patients with chronic disease. That is what's killing the health system. And then when you look at the demographics, 10,000 patients a day are joining the Medicare beneficiaries for the next 9 years, and 2/3 of them have 2 chronic diseases. That means some derivative of that number that started 8 years ago. So some derivative of that number is turning 10,000 at 75 and at 80 and 85. This problem's not going away, which is why Medicare's throwing these carrots out there. They want someone to come up with a solution. And the solution is having a chronic component for your chronic patients. Because episodic care, it was great when I was 5 years old and thought I was Evel Knievel and I jumped down the stairs and sprained my ankle. My baby boomer parents took me to the doctor's office the next day. It wasn't broken, and I left. That's when all of the visits were transactional, right? We had poison ivy and cold and flu and things like that. Today, you have urgent care at every shopping center, and they took the transactional business. And the baby boomers that took me to the doctor's office are now the 65 and 70 and 75-year-olds, complex patients with 2 or more chronic diseases. So the doctors have been left holding the bag on very complex patients. And the tools that would normally evolve in any market to offset those burdens got hijacked by meaningful use. Nobody developed any tools to help you keep track of your patients. Your customers changed. Doctors didn't miss a thing. What you missed was innovation that was working to track your patients. And because an office visit is still an office visit. The clinical magic that happens between an educated doctor and a well-informed doctor and a patient. And the patient needed an easy way to keep their doctor well-informed. That's the connection. That's what's going to bridge the gap. And that's what I built. And I knew to build it that way because when I was diagnosed at type 1, I was 30 years old. Before I was diagnosed, I weighed 215 pounds. I could run a 7-minute mile, and I was in very good shape. Type 1, as everybody knows, insulin-dependent type that juvenile, so you used to call it juvenile diabetes. When I finally went to the emergency room, I weighed 149 pounds. I didn't have enough energy to walk down to the mailbox and back. I couldn't sleep at night without just cramping up and being in excruciating pain. And I kept thinking it's going to go away. It's going to go away. Whatever it is, it's going to go away. Call it denial, call it whatever it was. But that morning I woke up, I realized I am not the CEO of this body anymore. And one of my friends came and found me at the hospital. I said, "How'd you know I was here?" He said, "Listen, if your car wasn't in your driveway at 8:30 in the morning, there was only one other place you were going to be. I mean, you look terrible." I called my parents and I told them from the hospital. I said, "The doctors told me that I have type 1 diabetes." And my father, who is a specialist, or who was a Green Beret and in Special Forces, he's known just for being very blunt. Started in the mailroom at General Motors and retired in the boardroom. He said, "Oh, thank God, I thought you had AIDS." I'm like, so you can imagine, but Dad, as far as I know, there's only 2 ways to get AIDS, Dad. And but 9 months later, I ran a half marathon in Atlanta, and because the point was is that I felt so lost and alone after I was diagnosed at home, because I called the doctor, I had to leave a message, the nurse would get it, the nurse would hopefully call me back, and I said, "My blood sugar is 180. What I learned about diabetes, I read online. It was up to me to educate myself. They gave me some materials, I read them all. But then I woke up and I know I'm supposed to be between 80 and 120, and now I'm 180. Like, that's 60% higher than my max. I got a problem. I didn't know if I was dying, right? So I call the office, leave a message, and then I'm like, just can't wait and I don't hear back. So I kind of developed that sense of anxiety. So what do? I call again, right? I'm that guy. I call again. I saw on my chart, this was 1999 or 2000, I saw on my chart, it said PITA. And I said, I'm not a member of PETA. And what I started dating a dietitian that worked there. I met her when I worked there, and she told me later that that stands for pain in the ass. So I got a lot to lose. I'm only 30 years old. And so those are those high anxiety patients. The difference is when you're 65 or 66 or 72 or 73, and you find out you have cancer or heart failure. These big words that you don't want. It's like salespeople where their base is too high. They get used to living there. They don't go out and try to make something happen. When you're at a larger age when you're older, at least this is what I've seen in my parents, they don't take it upon themselves to get engaged and to make sure that they're getting the care that they need from their doctor. They don't pick up the phone and call 2 or 3 times. And at least I know in my mother's mind, she started thinking about the fact that, well, I'm almost 80 years old, and maybe I have to start thinking about I'm kind of winding down. They don't fight as hard. And when they do that, their quality of life gets worse and worse. They end up in the hospital more and more, and they become more and more expensive, which won't allow you to succeed with value-based care. And the number one comment that we get from all our physicians, and Rosa can send this to you because we did a survey at the end of last year, 500 patients. The number one comment that we got from everybody is they feel more secure. 91% of our patients said that they were satisfied and that they were able to take better care of themselves. 75% said they have a better conversation with their doctor, although when you survey the doctors, they say they communicate with the patients. Let's say better communication, but less communication. Why? Because they're getting that red, yellow, green dashboard, and they can quickly click on that link and see Mr. Ferguson's blood pressure has been going up, and we've seen this recently. And we'll also tell you something that's interesting is when a patient says they've had more worse days than good days during this is neat what the data tells you. You can see that their diabetes, their fasting scores are worse. It's amazing. That type of data is going to tell us, it's coming over the next 10 years, going to tell us all kinds of stuff about caring for patients. There was a study out that the ACA put out on cardiac patients. And the number one predictor of cardiac patients that weren't keeping their plan, weren't maintaining their diet restrictions, is that they were lonely. Isn't that amazing? Now I can tell you that if I were at home, and I did feel lonely, I'm certain now that I look back, I was probably clinically depressed at some point. But I did feel very alone. I remember that. I remember just like, my sister called me and she said, "Oh, you're going to be all right." And she's the winner in the family. She was the teacher of the year here in Texas, and she works with special needs kids, and very like up to I think it's like 16 to 23, and she's like Napoleon in that room. I mean, she's got complete control. She graduated from business school way before I even thought about it, and so I've always been in her shadow a little bit. And she's like, "Oh, you're going to be okay." And I remember thinking to myself, how the hell do you know? Because the person I needed to know that I was under the care of was a doctor, not my sister. And so that's the point of why I knew this platform would work. People are stunned at 91% patient satisfaction and an 85 to 93% weekly patient engagement rate is probably higher than most of your med adherence rates. Patients with chronic diseases are lonely. I can't call, my mom's the matriarch of our family, she runs everything. And I remember sitting down with her when she was diagnosed with breast cancer. And I said, "Mom, we're here, we live in the same town, our whole family, everybody's gonna take care of you. We're all gonna do this. This is gonna be something we go through together." She's like, I know. And my little sister, who I love very much, but just constantly feels like we gotta keep her on track. And because I'm being recorded, I love her very much, and she's kind of high maintenance once in a while. My older sister was going through a terrible divorce, and my dad had early onset Alzheimer's and dementia, and she's the glue. She keeps it all together. She even picks up our kids from school once in a while. And so we sat down and talked about it, and she's like, "Oh yeah, I'm gonna be fine." I said, "Mom, I just want to ask you one question." Because she couldn't tell this to anyone, right? If she was worried, she couldn't let it out. She didn't want us to be worried. I said, "Are you lonely?" And she burst into tears. So I think about that a lot. That's why I am, from a mission standpoint, attached to this business, because I've been there and I've seen it affect my own family. But the great thing about this is, for you, is that when you go home and look at the numbers are really good. This is a platform that works. And it's great for patients. Essentially, everybody at the hospital and everybody at your doctor's office, we got plans on. But when we're blind in healthcare. We only know about them when they're episodically attached to us as an inpatient in our doctor's office or have home health visits. And there's that gap in between. They go home. And we don't know if that patient who just returned from the hospital has, if their sutures are red or do they itch, if they've had a bowel movement, if they're experiencing any dizziness, if you just go on and on. We don't know. We just hope that they followed the instructions that they knew. When they leave our office, and if at best you see them, a critical patient like once every month, well, that still leaves 354 days out of the year where we don't know. And if you don't have to pay a $40 an hour resource to get on the phone and call those patients to see how they're doing, which is financially impossible, you don't really have a way to know, right? Better informed doctors make better decisions. And when the patients will pick up or will engage or will answer the phone and tell a $12 an employee what's going on, and the platform says, call Mrs. Jones, ask her these 7 questions today. When you don't have a way to get that information, you're blind, and that's where the patients have changed. We went from having transactional business to having chronic business, but our tools are still set up for episodic care, and that's what we are. This allows you to know, okay, out of my at-risk population, 200, 300, 500 patients, these folks are fine. These are unhealthy, and we're watching some trends, and these are critical. You now will know. You have situational awareness of your entire at-risk population that's been enrolled every day. And that gives you the ability to do something about it. So this is what happens when they answer questions, and if any one of you want to play around with the app or want to see it or see your web online or how they answer questions, you can find out really quickly when you hover over that patient. It'll tell you what clinical thresholds they have exceeded. An MA typically picks up the phone, calls the patient by clicking on the phone number or through your regular phone system. Says, Mr. Rodriguez, was your blood sugar 181 over 122 this morning? Says, oh, I made a mistake. It was 122 over 81. Good. That's fine. They can override that answer. Everything is recorded. When they answered, what they put in, how much time they spent, how much time your staff has spent, all of it's done. And now you have basically situational awareness of that patient, and then when you click on that patient, like, okay, well, their blood pressure's definitely been going up. And if they've a red alert, it'll have a red alert. If they've gained weight, if they've noticed new swelling, if they are diagnosed with depression, and they say, I had more bad days than good days this week, and I just don't feel like there's a whole slew of clinical depression questions that are loaded in these protocols. Protocols are the questions that are asked and the frequency with which they're asked. They're not designed to diagnose a patient. They're designed to give you indicators and how quickly those indicators are adding up. We're trying to basically pull patients out of the at-risk pool, not tell you which ones are at risk, if that makes sense. We're trying to say this patient is stable. This one we have questions about. This one we can almost for certain tell you something's going on. But we don't call them and ask them and try to correlate that or communicate that to you. We tell you that these are the patients that need to be communicated, because those activities that you do get reimbursed anywhere from $42 to $264 per patient per month. And raise your hand if you have nurses already talking to these patients anyways. Well, you might as well track it and get paid for it. And doing that outreach, patients love it. The cash flow is phenomenal. This is a 3-doctor practice. It's a pro forma that we recently sent out. They are in Houston. It's incredible. Like when you look at what the revenue is on a monthly basis and on an annual basis, I told you it's a new golden era of medicine. RPM, that's 75% enrollment. That'll never happen. Forget it. End of the first year, 25% enrollment is not unreasonable. CCM, $230,000, RPM, $428,000. And remember, these are for the activities that your office is mostly already performing. We plug into the phone system, we get the call logs. We plug in on an active basis. We plug into the EHR, it's all pulled into the system. We get the activities, the refills, the changes, things like that. They can even go in, if you have Athena, it's completely integrated, but they can even go in and say, I did a pre-cert for this patient with XYZ. It's 3 clicks, and it automatically attributes 20 minutes, but you can just click and put 18 minutes. And then it's tracked, it's documented. The typical audit logs are 21 pages long for each month. You don't have to ever print those out on a piece of paper unless the auditor comes in. But the nice thing about audits, and I've been through a few of them, is they are done, this used to scare me, but they are done by people that are commission-based. So most RAC audit stands for Recovery Audit Contractor. Most of them are paid as a percentage of what they're able to fine your practice. So if they come in and say, I need this documentation for these 30 patients, and the average report is 16 or 17 pages long, and you bring out 480 pages of information and say, okay, let me know if you have any questions, because it shows we were on this screen monitoring this patient for 3 seconds. We were at this point in the EMR for 17 seconds. We did a pre-cert for this patient. We had 14 conversations with this patient or their caregiver this month, totaling 46 minutes. It's all there. It's not unreasonable to bill what you're eligible for when you can document it. And if you had to document all your staff's activities in a given day, you'd be like, oh my gosh. That's what happens. So they'll probably decrease those reimbursements once everybody starts doing chronic care management the way that we propose it, because it's so much work. I made this bigger so you could see it. And I think you ran a pro forma for a lot of the practice based on the Medicare. That's just the math. 50% is probably where you'll max out for the next 3 to 5 years. We don't have anybody that's reached 75%, right? That's the whole, hey, buy it. Look how rich you're going to be. Don't buy it because it's better for your patients and it's a manageable way to improve your value-based score things. But understand, there's money in the mission. And you're already earning it, you're just not billing for it. So my goal was to bring some clarity as to what's happening. MIPS is happening, it's already taking place. And that you'll hear transition to value-based care, et cetera. They're trying to get out of the fee-for-service model. Medicare's bankrupt in 2026, Medicare. The Undersecretary of Health and Human Services, or the prior Undersecretary under Tom Price, is less than a mile away from my office, and I know him. And he said the frightening thing up there is that the actuarial science in Medicare is far worse than what they're telling anybody, because they're saying that Medicare has not kept up with the billing rates, and commercial insurance is having to subsidize Medicare patients. So once that kind of starts leveling out, that's why you see the current administration promoting Advantage plans. Advantage plans show a 30% savings over traditional Medicare. So there's all kinds of rationing or tax increases that are going to have to take place. Point is it's happening. The ship has sailed. The laws are passed. The coding's already pushed into the fee schedule. It's moving. What I wanted you to have an understanding of when these things become important. You don't have to run out and start monitoring patients. You don't have to run out and start doing CCM, but you are expected to sort of have a strategy for how we're going to do this, because it is going to get worse. And then I wanted to show you with our platform, by keeping track of patients that will engage and will give you important data, how you can monitor a large population at scale and then use their information to manage by exception, which will improve your outcomes. The monitoring activities count as heavily weighted activities down here, and the outcomes are documented to reduce hospitalization, so how we will lower your cost, because MIPS is the framework that you follow. I don't think I put anyone to sleep, but it's a lot of data. You're going to have 1,000 questions over the next weeks, days, months, years. I told Rosa what I wanted to do is establish our partnership as an expert resource for you. And I hope I've done that. I'm happy to take any questions. And thank you for coming.